Live.
Good evening to all our viewers. Docplexus brings to you our special clinical wrap-up year-end master series of 2020. As evident from research and history, diabetes, hypertension, and nephropathy are indeed vertices of a Bermuda triangle. These three conditions go hand in hand. So, for today's webinar, we have with us Dr. Arun Kochar, who's going to highlight the intricacies of this Bermuda triangle. Introducing our speaker for today, Dr. Kochar is a senior interventional cardiologist at Fortis Hospital in Mohali. He has performed over 10,000 surgeries in the past 20 years of his experience. He was also pioneer in initiating radial interventions at Fortis Hospital. I, on behalf of Docplexus, welcome to you, Dr. Kochar.
Thank you. Thank you for the kind words. And indeed, it's a matter of privilege for me to speak on a platform given to me by Docplexus, and we'll be talking something which is very relevant to our clinical practice. So good evening to all ladies and gentlemen who have taken time out and are here with us to listen to this lecture. We'll be discussing about Bermuda Triangle, diabetes, hypertension, and nephropathy, and how it is important and why it is so deadly that we have named it as the Bermuda Triangle. So historically and at present as well, Bermuda Triangle is a triangular area in the west of North Atlantic Ocean. And it's near the Florida and beach, and it has been seen that many ships as well as aircrafts, they have vanished inside this triangle, and not much is known about the mystery why it's such a deadly area that so many lives have lost, and not much is known about this fact. In human body, we believe that a triangular representation of hypertension, diabetes leading to nephropathy or chronic kidney disease forms a triangle which is as deadly as the Bermuda Triangle is. And if you see this slide, the yellow of Bermuda could be represented by cardiovascular mortality and morbidity. Because in chronic kidney disease, the most important factor that leads to high morbidity and mortality is cardiovascular disease, and that is the prime reason that majority of the patients, they lose their lives. So why it's a common ground for hypertension and diabetes? In fact, both of them, they feed each other. And it's seen that hypertension is twice as common in diabetic patients, and new onset diabetes is also 2.5 times common in hypertension. If you look at the present data, almost 425 million individuals around the world are suffering from diabetes. And if you look at the hypertension data, it's almost 1.2 billion people around the world have hypertension. So with this mammoth staggering number of people suffering from both disorders, it's imperative that the together of this combination would be more deadly than either alone. And it's also important to know that both of them, they increase the propensity of developing the disease with each other, which again leads to higher mortality and morbidity. Even patients who have impaired glucose tolerance, they also go on to develop hypertension. Almost 20 to 40% of these individuals, they develop hypertension. As hypertension is common in diabetics, it has been seen that half of the diabetics, they have hypertension over a period of 5 years. As such, hypertension is very poorly controlled. Even in general population, it's very poorly controlled, and it is seen that only 10% of the hypertensives actually have their blood pressure under control. So diabetes is no exception, and when a diabetic develops hypertension, it's very poorly controlled, and that also leads to higher mortality and morbidity. The two together increases the CV risk by threefolds. So we can imagine that why Bermuda Triangle is being formed once we have the two limbs, hypertension and diabetes, in the same individual. Now, this was a study that was done in southern part of India by Dr. Bhavna, and it evaluated the young people with diabetes. So young onset diabetes mellitus is a form of diabetes where individuals who are less than 40 years of age, they develop diabetes. And that is probably due to the genetics and probably to the wrong lifestyle of our younger generation, that diabetes is developing at such a young age. So they actually evaluated at 7 center 1,500 odd individuals in a retrospective study, and then they found out that prevalence of concomitant hypertension in diabetes was around 27%. So India is no exception to the global phenomena, and hypertension and diabetes, they coexist in Indian patients as well. Now they both are interlinked. Why diabetics develop hypertension, and why hypertensives develop diabetes? It's majority of the times the pathophysiological basis, the grounds are similar in both disorder. Sympathetic overactivity and enhanced insulin resistance are probably the two most important reasons that patients with hypertension and diabetes, they coexist, and the same disorder coexist in an individual. Not to mention that most of the diabetics, type 2 diabetics, are obese, and that also they are suffering from dyslipidemia, and that also leads to pancreatic beta cell dysfunction, which actually leads to RAS activation and sympathetic overactivity, eventually leading to hypertension in patients of diabetes and diabetes in patients of hypertension. Chronic kidney disease is a nomenclature that we give to our patients based on their eGFR, estimated glomerular filtration rate, and albuminuria. So once we have found that our patient is suffering from chronic kidney disease, and if you look at the demographics, diabetes and high blood pressure, they form almost 75% of such individuals. So chronic kidney disease is again a culmination of the events of patients with hypertension and diabetes, and that leads to such high percentage of patients developing chronic kidney disease over a period of time. Not to mention that India is the diabetic capital of the world, and it is estimated by 2030 we'll have almost highest number of diabetics in the world. As far as hypertension is concerned, almost 1 out of 3 individuals in India is suffering from hypertension. And what is worse, that most of these diabetic and hypertensive Indians, they are not aware that they are suffering from such lethal chronic disorders. So what is the link that, chronic kidney disease, diabetes, it actually leads to cardiovascular death? So that is an important concept. As I mentioned early on, the yellow of the triangle in our slide was cardiovascular mortality and morbidity. So one important culmination of the axis where all these disease processes, they meet is renal and cardiac fibrosis. So it has been seen that diabetes as well as hypertension lead to various cytokine activation, which leads to cardiac fibrosis as well as renal parenchymal fibrosis. Now, once that ensues, that leads to left ventricular hypertrophy and progressive glomerular sclerosis. So that is actually hardening of the tissue, which eventually lead to adverse cardio-renal outcomes in the form of RAS activation and sympathetic overactivity, eventually leading to um, cardiovascular mortality and morbidity. So that is one algorithm that these patients of diabetes and hypertension and kidney disease, they eventually have high cardiovascular mortality and morbidity. Almost 80% of these individuals, they succumb because of cardiovascular mortality. Now, most of us believe that nephropathy is due to albuminuria, and that leads to chronic kidney disease, eventually to end-stage renal disease and death. Part of this hypothesis is correct, but recent evidence has suggested that there are other pathways to the development of diabetic kidney disease. So it's not only the proteinuric pathway, although that's the dominant process. There are other processes which are non-proteinuric pathways, which also lead to decline in eGFR. And many a times there are non-diabetic glomerulopathies, such as IgA nephropathy, which which contribute to the diabetic kidney disease, which contribute to chronic kidney disease or end-stage renal disease. Now, why this is important? Because the treatment algorithm are different in all these three pathophysiological processes. If it is a dominant proteinuric pathway, then the traditional ACE, ARBs, and SGLT2 inhibitors are helpful. If there are glomerulopathies for which we will need to do a renal biopsy, and we find that it's a non-diabetic glomerulopathy, then probably steroids and immunosuppressants would be useful. And if it is predominantly interstitial changes, then aggressive blood pressure control and lipid lowering would be beneficial in such patients. So renal dysfunction, as I mentioned, adds to cardiac and metabolic burden. And renal dysfunction, once it ensues in the form of diabetic nephropathy, also leads to insulin resistance, as well as ventricular hypertrophy, which eventually lead to enhanced cardiovascular mortality and morbidity. Now, what is the natural history of diabetic kidney disease? As I said, the dominant pathway is the proteinuric pathway, and most of the time, once we see a patient, we follow a patient of diabetic nephropathy, then initially for a number of years, he does not have any proteinuria. In fact, initially, there could be hyperfiltration, where his eGFR could be more than the normal. But it has been seen that gradually over a period of time, his albumin excretion rate, it increases, and his eGFR decreases over a period of time. And also simultaneously, initially it is a microalbuminuria, which eventually leads to macroalbuminuria, leading to end-stage kidney disease. Once patient starts developing microalbuminuria, we know that microalbuminuria is a risk factor for cardiovascular disease. It is also a risk factor for hypertension. These patients, once they have microalbuminuria, they also start developing high blood pressure. And that is one important culmination of index curve graphs where blood pressure starts developing in these patients. So what should be our treatment goal? How best we can treat these patients who have a complex interplay of hypertension as well as diabetes? Now, let us look at the guidelines. One of the latest guidelines had been European Society of Cardiology Guidelines 2018. Although we also have International Society of Hypertension Guidelines, which have come as early as 2020. Nonetheless, most of these guidelines, they have similar targets, and ACC AHA in 2017 and ESC in 2018 had recommended that in diabetic we should try to achieve a goal blood pressure of 130/80 and less than that. If you look below this column, there is also CKD mentioned there, where they have mentioned that the target blood pressure is 130 to less than 140 by 80 millimeter mercury, and ACC-AHA mentions the same, 130 by 80 millimeter mercury. So what does ADA says, American Diabetes Association? It says that most patients with diabetes and hypertension could be treated to a goal blood pressure which is less than 140 by 80 millimeter by 90 millimeter mercury. However, a goal blood pressure less than 130 by 80 millimeter mercury may be appropriate in individuals who are at a high cardiovascular risk if they can achieve without undue treatment burden. Here we need to realize that hypertension has a J curve. That means if you lower hypertension to a greater extent, then probably it is harmful. And all the societies now mention that a diastolic blood pressure less than 70 is not recommended. Because many hypertensive are frail and elderly, and that leads to orthostatic hypotension. And also the diastolic filling time is decreased, leading to coronary steal phenomena. So it is important that we realize that aggressive lowering of blood pressure is not recommended by any of the guidelines, and we need to stick to the target and should not be below 120 by 70. That is my own, personal guiding mark, and that has been endorsed also by different guidelines. However, they have not mentioned it like that. But we have seen that if blood pressure is lowered less than that, then probably that also leads to increased mortality and morbidity. So what should be the target blood pressure in hypertensive with diabetic kidney disease? This paper was published in Annals of Internal Medicine, and it tried to evaluate the role of blood pressure control, proteinuria, and ACE inhibition in a meta-analysis, and how best we can achieve the systolic and diastolic blood pressures in these patients. So they found out that a blood pressure goal around 130 millimeter mercury may be beneficial when the urine protein excretion is more than 1 gram per day. But if it is less than 110 millimeter mercury, then it is associated with higher risk of kidney disease progression. So that I have mentioned that we need to keep a lower guard as well, because if you lower blood pressure, it's a J curve, then probably it is not going to help our patient. In fact, it could be harmful as well. In patients who have proteinuria less than 1 gram per day, then probably 140 millimeter mercury would be beneficial in such patients. Another paper tried to evaluate the impact of blood pressure on mortality risk and end-stage renal disease in a large hypertensive population. This was NIH public access platform. This was published, and it evaluated that patients who have diabetic kidney disease, if you keep the diastolic blood pressure between 70 and 80 or 65 to 80, and systolic blood pressure between 130 and 40, that is going to help in the optimal management of reduction of events in your patients. So the hazard ratios has been mentioned, and if you look at the blue column, where the two J's are at the lowest nadir, you can find out that that is the optimal range of blood pressures which should be strived for in patients with diabetic kidney disease when we are targeting blood pressure for hypertension in these individuals. So that is saying what we have already said, that we need to be careful that blood pressure is not lowered excessively. Now, what does ESC says? 2018, it says that in whether patient is diabetic or a non-diabetic CKD, it is recommended that blood pressure treatment should be started either with lifestyle modification or BP lowering medication. when the blood pressure is more than 140 by 90 millimeter mercury. And it is recommended to lower the systolic blood pressure to the range of 130 millimeter mercury, that is class 1 level of evidence A. Now, ESC also endorses the same, that the target blood pressure should be 130 by 80, and we should strive that in diabetic patient. In CKD patient, when there is a proteinuria, again you can try to achieve a blood pressure which is around 130 by 80 millimeter mercury. So how do you manage uh, uh, according to ESC, how do you manage treatment with a combination of which drugs need to be given? Then all the guidelines recommend that RAS blocker are the mainstay of treatment for hypertension in such patients, even in non-diabetic uh, CKD, where RAS blockers have been found to be useful. Other than that, you can go for DHP, CCB, or thiazide-like diuretics, which are class 1 level of evidence A. A recommendation has been given to such patients. So in adults, even in younger children now, it has been mentioned that younger children, that is adolescent, that for patients with diabetes and hypertension, you should try to attain the blood pressure goal. And it is prudent to start with the thiazide-like diuretics or calcium channel blockers. However, in adults with diabetes and hypertension, ACE inhibitors and ARBs should be considered once there is presence of albuminuria, and these patients should be preferentially be treated by ACE inhibition. Now, what does ADA 2020 says? ADA 2020, in fact, endorses the same what has been mentioned earlier, that if albuminuria is present, then ACE or ARBs are preferred modality of treatment. And even if you are giving ACE and ARB, the blood pressure is not getting controlled, then it is prudent to add calcium channel blocker or thiazide-like diuretic, which can help in attaining blood pressure goal to our patients. So if RAS blocker is given and blood pressure is not being controlled, then CCP or diuretic should be recommended as the combination therapy. Now, what has changed over a period of time? Are we concerned only to attain the targets that have been mentioned, such as 130 by 80 millimeter mercury or a HbA1c level of 7? Are these the only targets? Much has been changed over recent 10 years, and one new molecule that has come up is SGLT2 inhibitors. They are a group of drugs which have been found to be useful, and they have changed the concept of treatment in patients with diabetes. So we have realized in last couple of years that it's not important to treat hyperglycemia alone in diabetics. It's not important to reach the target blood sugar levels which have been mentioned traditionally over so many years. More important is organ protection. So unless we are not protecting the target organs, the benefits will not be coming as far as cardiovascular mortality is concerned, as far as renal morbidity and mortality is concerned, as far as neurological events are concerned. So preventing that is helpful are SGLT2 inhibitors, which have shown that protection of the target organs is more important than hyperglycemia. If you look at the SGLT2 inhibitors efficacy, they are able to lower HbA1c to a very modest 0.5 to 0.8 percentage points. So which is actually very modest compared to glimepiride or sulfonylureas. But if you look at the benefits which SGLT2 inhibitors confer to the patients who are given SGLT2 inhibitors, then you see that there is it cannot be explained solely on the basis of a reduction in hyperglycemia. They have pleiotropic effects, and they have been found beneficial in so many other ways. So this is one mechanism of action. I believe most of us know this, that SGLT2 inhibitors, they work at the proximal convoluted tubule, and they help in promoting glucosuria, and also along with that there is a volume loss that helps the patient in reducing his interstitial volume, weight loss, his blood pressure becomes improve better, and the benefits are seen with a number of other effects that ensue once this phenomena starts happening. Once you give SGLT2 inhibitor, you'll realize that there is initially a hyperfiltration in the initial stages of SGLT2 inhibitor once they are started. The eGFR may dip for a while, but eventually it will become stabilized. And uh, once these patients are followed up for long, it may actually become better. Now, there are many potential mechanisms of action, and none is much known about this fact. Couple of them I have mentioned, that it's interstitial volume loss, and it's glucosuria that is happening, improvement of blood pressure. There is uric acid also, which is getting less, and cardiac energetics, they also improve. The cardiac energetics shift to ketone bodies, which are more efficient. It decreases the propensity of arrhythmia by stabilizing the membrane potential, and a host of other effects. It is also suggested that it leads to decreased sympathetic overactivity. It actually also helps in inhibition of RAS processes. So there are many effects, and probably it will take us a long time before we realize which is the predominant effect. Sufficient to say at the moment that SGLT2 inhibitors are probably as pleiotropic as statins had been, and they help in patients even those who are not diabetics. So going back again, just to emphasize that mortality is more frequent in diabetic patients with kidney disease than those who do not have kidney disease. The why we have taken this slide is because of this, that once we have kidney disease, once we have a patient of diabetes, then we need to have a molecule which could be given, which could reduce major adverse cardiac events, which could reduce CV death, heart failure hospitalization, as well as renal endpoints. So they are very important, because once renal is involved in diabetic patient or a hypertensive patient, the mortality rates are very high. So unless we do not have a molecule which can act both on the heart as well as on the kidney, we may not be able to prevent total mortality. So SGLT2 inhibitors have proven that they are helpful in reducing albuminuria as well as total mortality, cardiovascular mortality, and renal death as well. Now, there is, debate that they are complementary or they are the same action as RAS blockade. However, the best we can say that SGLT2 inhibitors are complementary to RAS blockade. We know that SGLT2 inhibition leads to afferent constriction that leads to decrease in glomerular pressure, whereas RAS blockade leads to efferent vasodilatation. So actually both the molecules are causing decrease in intraglomerular pressure, which reduces albuminuria. However, one is causing afferent vasoconstriction, which is SGLT2 inhibitors. The other is causing efferent vasodilatation, which are the RAS molecules, RAS inhibitors. So we have good trials of SGLT2 inhibitors, no need to tell them, but AMPA-REC, CANVAS, DECLARE, and CREDENCE trial. They were very large trial. DECLARE was perhaps the largest CVOT trial that had taken place, almost 17,000 patients. And all these trials, if you look uh, at the kidney disease progression endpoint, then all these trials have proven that they are better than the placebo, because for the line of unity, they are on the left side, and the hazard ratios were significant, statistically significant, with a relative risk reduction to the tune of almost 30 to 40%. So that means that giving these molecules reduce the renal disease progression. So coming back to what we have just talked about, if a patient of diabetes has hypertension and also has CKD, it's important to protect the organs. It's not only achieving the goal of blood pressure, achieving the goal of HbA1c, or trying to have a eGFR which is not progressing fast. More important is to protect the organs, and for that, SGLT2 inhibitors are the molecules of choice, and that is why they have been endorsed by various world guidelines. A last slide, I believe, or a couple of 2 or 3 slides left. So DAPA-CKD trial I like to mention here. It was one of the landmark trial which was published in ESC Congress 2020, a virtual congress this time because of COVID-19. And Dapagliflozin was assessed in patients of chronic kidney disease, even patients with diabetes, and even in patients who were non-diabetics. So patients of CKD, whether or not they had diabetes, were evaluated in 1:1 fashion versus placebo, 2,152 patients in each arm. And the primary composite endpoints was worsening of kidney function, or onset of end-stage kidney disease, or death due to kidney disease, or CVD. So cardiovascular events were also calculated, and it was seen that there was a 39% relative risk reduction when Dapagliflozin was given to such patients. So once Dapagliflozin is given in patients of chronic kidney disease with eGFR which was more than 30, then it was seen that actually these patients had less worsening of kidney function, less deaths from cardiovascular disease, and less death due to kidney disease. When Dapagliflozin came initially, it was taught to us that it should not be given if eGFR is less than 60. But it is now seen that dapagliflozin is actually very helpful even when eGFR has gone down to 30. So that has been proven, and we now have evidence that it can be safely given in patients of chronic kidney disease. So KITCO 2020 diabetes guidelines endorse that SGLT2 inhibitors should be added to anti-hyperglycemic medications. They have gone a little over the board as well as far as SGLT2 inhibitors are concerned. If you have a patient of CKD and you need to add an anti-diabetic agent in such individuals, it is better that you start with metformin and then you add SGLT2 inhibitors. If you are able to reach the glycemic target by giving SGLT2 inhibitor to these individuals, it's good. But if you believe that the glycemic target is not being attained, then it is better to stop the other anti-hyperglycemic agent and continue with SGLT2 inhibitor rather than persisting with the other anti-hyperglycemic agent, meaning thereby that SGLT2 inhibitors are the most important drugs that need to be given to the patients of diabetes if you wish to control the diabetic status after metformin. And if you have other agents such as DPP4 inhibitors or any other agent, it is better to stop them and go in favor of SGLT2 inhibitors. So that is the KDICO 2020 guidelines, which say that any patients of CKD with a eGFR of more than 30, SGLT2 inhibitors should be preferred over other anti-diabetic agents apart from metformin. And if you are able to go along with other anti-diabetic agents, then it's no problem. But it's better to go with SGLT2 inhibitor. They are a must in your therapy, in your management regimen, and they must always be included apart from metformin. So that was all, friends, about Bermuda Triangle. I'll summarize by saying that Bermuda Triangle is a very deadly combination of diabetes, hypertension, and nephropathy. If a patient gets into this triangle, it's very prudent to be vigilant both on the part of patient as well as on part of doctor. We should strive to go for organ protection rather than merely looking at the numbers. So that is the carry home message after last decade of trials which have come up. And organ protection is best afforded by ACE inhibitors, ARBs, and SGLT2 inhibitors. Not to mention GLP-1 analogs have also been endorsed by world bodies, can also be given to these patients for preventing the damage to the target organ. Don't forget the target organs are heart, brain, kidney, apart from eyes and lower limbs. So they are also target organ, but most important target organ are, in my view, are heart, followed by kidney and brain. So if we have included the molecules which have proven in randomly useful in such patients, then probably we are doing justice, and our patients of Bermuda Triangle, they'll be living longer with a useful questions. I'll be very happy to answer them.
Thank you, Dr. Kochar, for such an informative and enlightening talk. We have received a very overwhelming response and questions from our viewers. So we'll go ahead and I'll ask you the questions one by one.
Definitely.
So, how are you managing your patients with hypertension and diabetes in between this COVID-19? I'm sure many doctors would have the same question since this past 1 year has been very challenging time for the healthcare providers as well.
So I'll summarize my answer by saying that it's not much different than what it was before COVID-19. Initially, there was a apprehension that the coronavirus gets inside the lungs by attaching to ACE2 receptors. But then eventually it was found out that ACE inhibitors are actually protecting, ARBs are actually protecting, because once you give ACE and ARBs, then ACE2 levels, they that actually increase in our patients who are receiving these drugs. But the organ protection that is offered by ACE and ARBs are actually protecting, and most of the guidelines these days, they endorse that we need not stop ACE ARBs in our patients who are hypertensive, and they must be continued. As far as diabetes is concerned, it is important that we should be aware that patients of COVID-19 have propensity to develop hyperglycemia, and many a times insulin need to be added in such a situation. Also, many a times these patients are hospitalized in severe conditions where we need to look at the medication which cannot be given in heart failure or which cannot be given in extreme kidney failure in such a scenario. So, meaning thereby that probably drugs such as insulin have a better role to play once these patients are hospitalized. Otherwise, for ambulatory COVID-19 patients, we need to continue as it has been before COVID-19.
Thank you for the detailed response. Another question is how central obesity is related to diabetic nephropathy.
Well, central obesity is apple-shaped obesity. And if you realize, I said that almost 425 million individuals around the world are suffering from uh, diabetes. If you look at the obesity indicators, then almost 650 million diabetics are living with 650 million individuals around the world are living with overweight and obesity. So that is how common this food disorder has become. If you look at USA population, almost one third of the US population is overweight. Even in our own country, it has been seen that almost 20% of the school going children, which are of the age group of 12 to 18, they are overweight in urban scenarios. We are not talking about the rural uh, framework. In a city like Chandigarh, almost 12 to 18% of our children are overweight. So actually, being overweight or obese confers a very high risk of developing diabetes. It has been mentioned statistically that obese patients have 80 times more risk of developing diabetics than patients who are non-obese. So that is the risk that has been conferred by being overweight. And partly it is because the obesity patients have so much fat in the body, the visceral fat, that there is a enhanced inflammatory response. And this inflammatory response is probably due to the cells which are overfed with fat, which are overfed with nutrition. And that leads to inflammatory response in the form of enhanced cytokines. These cytokines lead to insulin resistance. Also, the extra fat is deposited as ectopic fat in liver and muscles, which also contribute to insulin resistance. This ectopic fat is also concentrated around heart. One of the potential mechanism of SGLT2 inhibitor benefit is that it reduces this ectopic fat. So these are actually hypotheses, but that is one method that obese patients tend to develop diabetes and followed by nephropathy. So obesity leads to diabetes, and then diabetes lead to chronic kidney disease. So that is how this gameplay come into force. Our 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 knowledge would be sufficiently worthwhile if we do something to stop this eating disorder in our younger children. We could advise them to go for contact sports as well as stop eating junk food. This is also important for the adult population as well, because if you maintain a healthy lifestyle, then probably you can prevent this preventable transmission of obesity to nephropathy.
Sir, we totally agree with your answer here. We have another question from Dr. Ahmed who says, could you please highlight the role of ACE inhibitors in managing diabetes and hypertension?
So as I said, that ACE inhibitors modulate the tone of efferent arterioles that leads to fall in intraglomerular pressure, which leads to whenever the intraglomerular pressure will fall, the albuminuria will decrease. So as we had understood that albuminuria is the core principle of progression of diabetic kidney disease. So one method is that the albuminuria is getting lower down, that is reducing um, the progression of microalbuminuria to macroalbuminuria to end-stage renal disease. Also, ACE inhibitors are able to prevent the harmful effect of angiotensin 2. Angiotensin 2 is one of the most important vasopressor known. These vasopressor, they cause vascular hypertrophy, they reduce the endothelial function, they also lead to renal parenchymal injury. So once you are able to reduce the harmful effect of angiotensin 2, which is also increasing the sympathetic overactivity, which is also increasing the aldosterone hypersecretion. So once angiotensin 2 is reduced, you are able to prevent all these harmful effects that helps the patient of Bermuda Triangle, and his nephropathy is becoming better by giving ACE and ARBs.
Thank you, sir. So there's a situation-based question. It asks like that. It says, is stopping a beta blocker indicated if the pulse rate below 55, but BP well controlled and patient above 60 years?
Well, beta blockers need not be given if the heart rate is 60 or less than that. So
Okay.
one of the target of giving beta blocker to our patient is that we need to reduce the heart rate to around 60. So once you have a patient who's now 60, I won't call it as a old age, because now we believe that our patients are entitled to live for almost three figures. So 60 is not an old age, but anyway, it's on the wrong side of 50. So it's better that you do not give beta blocker to a patient whose heart rate is already less than 60. You have already attained the benefits that were needed of beta blocker. It is also important to know that why beta blocker is being given to such a patient. Is it because of hypertension? Is it because of heart failure? Or it is because of his adrenergic stress, because that is also one very common indication in OPD to prescribe beta blocker. You find an individual who's very tense, who's very anxious, and you give small dose of beta blocker so that his anxiety levels go down. We know that anxiety neurosis is one common indication, migraine is one common indication for giving beta blockers. So probably a patient who's having heart rate of 55 may opt for other drugs than beta blocker.
So there's a last question which says metabolic syndrome has been linked with increased risk of microalbuminuria. How frequently should this be checked for a patient with three or more traits of metabolic syndrome for early detection of the damage?
So I'll suggest every year we must check our patients. That has been mentioned in the books, in literature. Every year almost, if it is normal, right? If it is normal, then it's every year. To call it abnormal, there should be microalbuminuria or macroalbuminuria with two readings which are 3 months apart. So that is for the abnormal. And if you find that it's normal, then keep checking every year. And once you have confirmed that your patient is suffering from albuminuria, then you need to check it almost every 8 weeks or so to know the response of therapy and also to know the progression of disease.
Thank you so much, Dr. Kochar, for making the webinar so interactive. More than the presentation, I feel your expertise over the subject has been the apex of the talk. On
Thank you.
behalf of Docplexus and the entire community, I would like to thank you again for taking out time from your busy schedule and talking to us live on such a pressing issue. We are highly obliged, sir. Thank you
Thank
so
you.
much.
I wish you all a very good evening and stay safe and have a good time. Have a good evening. Thank you.
Thank you, sir. We also wish you a very happy new year 2021.
Thank you. Same to you.